This slideshow is for HIT 197, Professional Practice 1, Unit 2 Disease Case Study, Kawasaki Disease by Jill Thorson. Kawasaki found his first case of Kawasaki disease in 1961. He first reported it in a Japanese publication in 1967. At the time, it was controversial as to whether or not Kawasaki disease was linked to cardiac complications. In 1970, however, Japan performed a nationwide survey of deaths linked to Kawasaki disease and determined that cardiac complications were in fact linked to them. Kawasaki published his findings in an English language publication in 1974, by which time coronary artery vasculitis and Kawasaki disease was well established. In America and Japan, Kawasaki disease is now the leading cause of acquired heart disease. It is unknown what causes Kawasaki disease. However, due to clinical presentation as well as epidemiology, it's believed to be either an infection or an abnormal immunological response. It's also possible to be an autoimmune disease. The majority of cases of Kawasaki's disease occur in children under the age of 5. The disease does occur worldwide. However, it is particularly common and high among children of Japanese descent. Clusters have been reported in communities, yet there is no clear evidence of it being spread from one person to another. The symptoms of Kawasaki disease. Stage 1 generally lasts 5 days, with a fever of over 102 degrees Fahrenheit. It can be accompanied by intermittent colicky, abdominal pain, irritability, and occasional lethargy. After 5 days, stage 2 begins. It usually begins with a rash primarily over the trunk, an injected pharynx, dry fissured lips, and a red strawberry tongue. Coronary artery disease can occur especially in younger infants. In about 50% of patients, non-supportive cervical lymphadenopathy is present. Diagnostic tests. The main diagnostic test is clinical criteria. Among those is changes in the lips, tongue, or oral mucosa, changes in the peripheral extremities, truncal exanthem, bilateral non-exudative conjunctival injection, and Kawasaki disease can also be determined through serial ECGs and echocardiographies. These are generally done several weeks apart to continue to monitor for cardiovascular disease. There are also other tests such as CBC, rheumatoid factor, liver enzymes, throat and blood cultures, and a chest x-ray done simply to rule out other disorders prior to diagnosing Kawasaki disease. Children with Kawasaki disease are at a higher risk of developing coronary artery disease than those without Kawasaki disease. With therapy, the symptoms will usually subside in 2 to 12 weeks, sometimes longer. There is a risk of recurrence months or even years later. The treatment for Kawasaki disease is high-dose therapy of immune globulin IV and aspirin. Children should also consult with either a pediatric cardiologist, pediatric infectious disease specialist, or a pediatric rheumatologist. Complete recovery is usually seen in patients that do not develop coronary artery disease. Most of the deaths linked to Kawasaki disease are due to the cardiac complications later on. With therapy, the mortality rate in the U.S. is 0.17%. Thank you for listening and have a good day.